Good afternoon, dear Commission, heads of the Commission, and listeners. I'm very glad to participate in this conference, despite the fact that today it took such an unusual form. Anyway, I'd like to narrate about polypharmacy in treatment of arterial hypertension and heart failure, which is my today's topic. So, despite the development of medicine, there are still many diseases against which we do not have any weapon. Moreover, there are such diseases that now occupy the first places of morbidity and mortality. One of these diseases is hypertension, and another one is its complication, the heart failure. Despite the achievement of last decade in the field of studying this disease, chronic heart failure and arterial hypertension is still one of the most common, severe, and predictable complications of all diseases in the cardiovascular system. Due to the fact that these diseases are extremely common among the adult population, often patients have a concomitant disease. Such diseases, for example, are arthritis, gout, dementia, Alzheimer, and so on. Therefore, in the treatment of such diseases, doctors are faced with polypharmacy and, moreover, polypharmacy. Polypharmacy occurs in approximately 56% of patients younger than 65 years and 73% of patients older than 65 years. The prescription of two drugs, for example, leads to their interaction in only 6% of patients. However, the appointment of 5 drugs, which is not uncommon in modern cardiology, increases the frequency of drugs interaction by up to 50%. Not surprisingly, that simultaneous administration of 10 drugs must cause reactions between them in 100 of cases. The two main mechanisms of drug interactions are the change in pharmacodynamics and pharmacokinetics. Pharmacodynamics interactions refers to cases where the change in the effect of the drugs is not associated with change in the concentration of the drug at the target receptors. So, we want to investigate the frequency of use of polypharmacy and the risk of drug interaction. And our task were to analyze the efficacy and safety of the therapy and to identify groups of medicines with potential risk for cardiac patients. Now I will show you some methods and materials of research. Taking into account treatment protocols, we can proceed the part-check assignments in daily practice in order to compare protocols with the real assignments. In addition, the comparative approach allows to analyze the interactions of these drugs and the volume of prescribed drugs. We analyzed the data of history of disease of patients of the therapeutic profile in 2008 and 2018 years. The interval of 10 years is chosen to the possibility of analyzing the changes in the principles of therapy and certain characteristics of patients. Now I want to show you two diagrams. The first diagram on this slide shows us the ratio of diseases of all patients that were treated in therapeutic department in 2008. As you can see, the biggest part is here, takes the hypertension together with coronary heart disease. Right after it stays hypertension and coronary heart disease separately. And now what happened in 2018? We can clearly see that the number of patients with arterial hypertension and coronary heart disease is quite similar, but the percentage of patients with independent hypertension is significantly higher than in 2008. I should also emphasize on third-degree hypertension, which occurred in 2018 with almost 5% of people. Now, after we analyze the situation in general, let's describe the actual treatment of the patients. Speaking about all patients in general, most often was appointed theotic acid or meldonium, that's cardiological drugs. And in second place stays ACE inhibitors, it's about 8%. And third place is beta blockers. Also, a large proportion is occupied by nootropic drugs and drugs that affect the nervous system, and the drugs that affect the digestive system, as well as polyenzyme preparations. Now let's speak a bit more specific about the drug prescription in cardiac patients group. Here you can see two tables which show the difference in prescription between 2008 and 2018 years. I specified a group of drugs which were prescribed the most. Of course, for us, most important drugs were those which can be used according to the treatment protocols. This group includes diuretics, ACE inhibitors, calcium channel blockers, beta blockers, and ARBs, of course. The prescription of diuretics in our cases were extremely small, so they don't even have their own column, but other drugs are in it quite often. Firstly, I want to draw your attention on ACE inhibitors. During 10 years, the use of these drugs has almost doubled. This group is also more popular than beta blockers. Speaking about beta blockers, the use of these drugs also increased, but not so significantly, and the use of calcium channel blockers is declined. And now let's talk about polypharmacy, which is today's our topic. The table shows the percentage of prescription with certain number of drugs. So to make it clear, do you see these two green columns? They show us the percentage of normal number of drugs during the treatment. As I already wrote, the term polypharmacy means the simulation administration to a patient of a large number of drugs is like more than 5. When doctors prescribe 6 or more drugs at the same time, we can never predict the side effects that may occur. So the more drugs doctor prescribes, the worse consequences can be. Coming back to our table, we can clearly see that the number of cases with exceeded amount of drugs is much bigger than the normal one. It's like 29% versus 71%. Here is a similar table, but here we used only cases with cardiac patients with chronic heart failure without concomitant pathology. So imagine there is a person who has only chronic heart failure and nothing else, and some doctors treat them with 10 drugs or even 11. Even 9 or 8 is too much. Moreover, a lot of them were completely not in step with treatment protocols. On this slide, you can see the medicines that were prescribed most often. On first place stays AC inhibitors, on second place cardiological drugs, that's steatotic acid and meldonium, and third place took nootropic drugs. Interesting, right? Seems like our doctors cares not only about physiological state of patient, but also about mental health. Beta blockers, which stays in first line of treatment of hypertension and chronic heart failure, took only 5th place. What is not so bad because ARBs, for example, didn't find their place at all. I also want to pay your attention on the last column. It's diazepam. Now let's speak about risks of drugs interaction which took place in some cases. Firstly, the simulation use of NSAIDs and antithrombotic drugs increase the risk of bleeding through the pharmacokinetic interaction. NSAIDs have a high affinity for blood plasma protein, thereby the free anticoagulant fraction is increasing. And in 2008, 2 patients, and in 2018, 1 patient were discovered to have this dangerous combination. Secondly, a prescription of slow-free calcium channel blockers and beta blockers lead to emission of the effect of slowing down the heart rate that may lead to cardiac blockade. If necessary, a simulation application of beta blockers and calcium channel blockers preference is given dihydropyridine calcium channel blockers. And some patient treated in 2008, there was like 1 cases who discovered with this really dangerous combination. And in 2018, this combination was not detected, what is quite good. Third, corticosteroids and antibacterial form the fluorochronomycin group may damage the tendons. This is especially important information for a physiotherapist who wants to prescribe this medicine to the elderly. In 2008, 3% of patients had this dangerous combination, and in 2018, only 2 patients. Fourth, AC inhibitors and potassium-sparing diuretics can lead to the development of hyperkalemia, which carries danger on the development of fatal cardiac arrhythmias. In 2008, 2% of cases were found, and in 2018, only 1 case. Fifth, AC inhibitors in prescription with ARBs have a negative effect on kidneys, and this combination in short time can lead to the development of kidney failure. And since 2013, the simulation reception of data of drugs is not recommended. The combination of AC inhibitors and ARBs occurred in 1 patient in 2008, and since this time there was like no these combinations. And 6, antiarrhythmic drugs and highly active diuretics prolong the QT interval. QT prolongation is a predictor of fatal cardiac arrhythmias. Antiarrhythmic drugs along with furosemide increase the risk of developing ventricular cardiac arrhythmias, which in turn can lead to sudden death of patient. In 2008, 1 patient had this combination of drugs. Therefore, by the analyzing of pharmacotherapy of patients with hypertension or chronic heart failure over 10 years, the number of dangerous combinations of drugs has significantly decreased, but the question of polypharmacy remains relevant. And it seems like we came to the conclusions, which are, first, pharmacodynamic interaction occur much often than pharmacokinetic, namely, dangerous interaction occurred in 10% of cases. Secondly, polypharmacy is observed in 70% of appointments, which increasing the risk of complications of treatment due to the unwanted drug interactions. And thirdly, in 2018, dangerous drugs combinations were prescribed 3.8 times less often than in 2008, which indicates an increase in physicians' professionalism. Thank you for attention. Do you have any questions?
Thank you, Sophia. Please, questions.
Ой, что-то произошло. На секундочку.
Olga Viktorovna and her computer has some problems. And do you have questions? I begin.
Sure.
What do you know? You listen me?
Yeah, sure.
What do you know about World Health Organization recommendations to quantity of medicines for one course of treatment?
Thank you very much for the question. That's quite an interesting question. So, World Health Organization recommend no more than 5 drugs, because even where there's like less than 5 drugs, sometimes it's really hard to predict some interaction between them. But when it's more than 5, it's like really, it's unreal. I'd say it's unreal to predict, because every patient has like some personally.
Yes, I see. And second, what would be your practical recommendation in this case? For example, if you were a clinical pharmacist.
Wow, thank you very much for this question. Well, if I'd be clinical pharmacist, I would first of all recommend to doctors to treat patients like, okay, imagine there is a patient, for example, old
for one course of treatment. For one course.
Yes. So we treat only like the main diseases. When we can treat like even hard diseases can never treat with more than 5 medicines. So we'll treat them with, for example, 4 or 5 medicine maximum. After that, if this patient have a contaminant disease, after the treatment of the first one, we can treat with another one. And so with all time, there will be no more than 5 medicine at the same time. So we'll treat him without pharmacodynamic or pharmacokinetic interactions.
Thank you. Any other questions, please? Members of our jury.
No.
Have not questions?
Oh, wait, there's in the chat.
Maybe in chat, maybe in chat.
1 second. Okay, so could you tell this number of drugs always are controlling or not? Yes, of course. Even if we prescribe less than 5 drugs, like 3 or 2, we should always control the state of the patient. We should make some analysis, and of course, we just look after patient and his state. So yeah, we should control any number of drugs. Anyway, I hope I answered the question. And next one, as I see, are there any features of quantity of drugs for different age groups? Yes, thank you for this question. It's a really good one. So yeah, okay, there is a different group of patients. First one is like kids, as we know. Second is with just not elderly, but like normal age from, let's say, 18 till 45. And the next one is elderly. Kids and elderly has less cells in blood that can catch our drugs. So usually this group of patient treats with like less quantity of drugs. Yes, and we should control this state. And when we're speaking about elderly, we should also see if there's a contaminant chronic diseases which can also occur.
Is it all? Are you satisfied, Людмила?
Another one.
Thank you, Natalia Lekperova.
Thank you very much.
Here.
So, which diseases are mostly affected by polypharmacy? Wow. So, honestly, there's a lot of diseases, especially in our country, who faced with polypharmacy. Because, well, I can't even find a reason, but some doctors really think that like the more drugs they prescribe, the better the patient is. And moreover, some patients mostly from elderly groups, they think that like, okay, if doctor prescribes me like 10 drugs, it means that like this doctor is really good. So they really want to be prescribed the big numbers of drugs. And as you already saw in my presentation, cardiac diseases faced up with polypharmacy. Also, I should say that diseases that meet like gastrointestinal tract and chronic one also, and also probably nervous diseases which connected with nervous system.
Okay.
Are you satisfied, Natalia?
Probably, yeah.
Thank you very much.
Olga Viktorovna,
I'm here,
are you here? Are you with us?
I'm here enough. Yeah. Does anyone have any question? No? Thank you, Sophia.
Thank you very much.
Yeah.